أنا حابة أناقش ليه احنا اخترنا موضوع السيشن. احنا عندنا قضية مهمة قوي دلوقتي في مصر. القضية دي ظهرت في الفترة الأخيرة بسبب إنه في مشاكل محيطة بعلاج الإدمان. أنا هحاول أبقى يعني mainly in English لأنه في أجانب كتير قاعدين معانا، بس في حاجات تخصنا فهقولها. Okay, thank you. The first point is how the journey for treatment of addiction starts. Who is involved in the treatment of addicts? What's the problems affecting the results at the end? And what's the role of the legal issues to control this journey for the benefit of the patient at the end? Let me tell you how it goes on in Egypt on the spot. At the beginning, a family discovers that one of her sons or daughters is having a problem of addiction. How do they discover it? This might take few years until they discover the problem. This is related to the awareness about the problem of addiction. What are the signs that can tell that this boy or girl is going through this problem? They would spend a lot of time asking, is it a disease or is it a misbehavior, and where to go? Should we go to a doctor? Should we search medical treatment? Or should we try to correct this misbehavior? To tell that it is a disease, a brain disease, an organic disease, it takes time to be accepted. Because by time they understand we are having a problem that couldn't be controlled by some limitations and rules and regulations for the boy. Then they go for treatment. Where should they go? They go for physicians. Sometimes they ask that treatment should be done at home, not in a hospital. When can we accept this? At what extent should we say he has to be hospitalized? Hospitalized where? In a hospital or in a rehabilitation center for treatment of addiction? Should he take treatment or we go with psychotherapeutic measures without giving treatment? For how long do we need to give treatment at the beginning and then we shift for psychotherapeutic measurements? Next point, how long this treatment will take, and can we do it in a halfway, or should we be related to a doctor? Can we take treatment for long term, or we need other measures for relapse prevention without involving drug treatments? What treatments can we use? I'll give an overview about it very rapidly, and where is the problem do we have? Another issue, where the role of the doctor starts and where it ends. Where is the role of the psychologist or the social worker and where it ends? Where is the role of the recovered addicts? And do they have the license to work with patients or not? What do they need to be trained for in order to join the therapeutic teams? And where is the legal issues that govern these issues? Is it the role of doctor? Is it the role of centers? Is it the role of hospitals? And what's the problems? The problems is that we have now scattered areas and centers all over the country. Some of them are licensed, others not. Who is working there? Who is supervising these patients medically? What is the cost for these patients and what's the benefits? What do they go to these centers and refuse others? The first step is the medical detox. We have lots of issues about it. Do all drugs need medical detox or not? If the patient is taking cannabis, if he's taking synthetic cannabinoids, if he's taking alcohol, if he's taking opioids, do we need detox for this or not? And the duration for detox, is it 1 or 2 weeks or maybe extended for 1 month? The next point, the detox to be done where? In a toxicological center or in a psychiatric hospital with a detox department where the patient joins at the beginning and then he will be transferred to the addiction center. In Ain Shams University, we have addiction unit, and the addiction unit is divided into 3 points. The first one is the entry through the outpatient clinic or the ER. If he is physically okay, he will be admitted to the detox unit, maybe for 1 to 2 weeks until all the symptoms of the withdrawal period is treated symptomatically, and then he will be transferred to the addiction unit to join the start of the program. The next point is to treat him as an outpatient, or he has to join a residential program. It depends upon the duration of substance abuse as a disease. Number 2, the type of substance, the dose, the complications, and in some patients taking only cannabis, he can be treated as an outpatient. How many times do you receive him as an outpatient? And then when you have to admit him to the hospital. Now we are having a problem of synthetic cannabinoids. Most patients present with psychotic symptoms, with bipolar symptoms, with irritability, with agitation, and in spite he's taking synthetic cannabinoids, he needs to be admitted inside. Long-term residential treatment versus the short-term. How long should we admit him? We have shortage in the number of beds to put patients for a long time. I mean in the National Health Services, in the university hospitals, we can only put patients for a few months, maybe for 2 or 3 months, that's maximum. But I cannot put him there for 6 or 12 months because we don't have enough beds for this. Therapeutic communities, is it available under the right term of therapeutic communities? Does it have the legal issues that govern their practice or not? Who is managing the patients in this way? Therapeutic communities, they should be highly structured, and they should address all the patient issues, and they should sensitize with their experience, and giving a belief system that we are trying to help the patient from different points of view. Again, is it applied in the right way or not? We have nonprofit organizations. They are trying to run centers, but do we have structured therapeutic communities working on the floor in the right way? Questionable. The cost benefit is putting the patient in a residential care for longer time means that you are putting him in a protected, closed environment, which means he's not taking substance anymore, and it is safe to give him treatment during this period. But if he is outside, you are not sure enough that he is not taking the substance beside the treatment with more complications. Again, if he is joining a medical service, it's very easy to test for and assess for other medical comorbidities. We have very high levels of HIV, reaching about 20%, HCV reaching about 40 to 60%, and most of them were treated through the HCV treatment programs in the past 2 years. It's suitable for those with long history of addiction who fail to pass the short-term addiction programs there, and they have comorbidities. We have comorbidities, medical and psychological, of personality disorder, borderline, antisocial, psychosis, and we have separate units for dual diagnosis. The short term, from 2 to 3 months, usually it is done in hospitals at the beginning, and he is totally closed inside. They receive medical treatment plus the psychotherapeutic programs, and they start there the programs for relapse prevention. Outpatient treatment, when they are discharged from the hospital, they join the outpatient clinics, and there they come for follow-up every 1 or 2 weeks, and they receive treatment enough for this period. The treatment usually is in the form of medical treatments, plus for depression, for anxiety, for impulsivity, and also for addiction. For addiction, we have available some treatments, antagonists mainly. We don't have the methadone program up till now, but it's on the, to evaluate admitting it into the National Health Service. We don't have the Buprenorphine on table right now, but also it is considered to be added. The Buprenorphine is discussed to be added in the form of tablets, or in the form of patches, or in the form of injections. All of them are not allowed up till now. We have the Naltrexone. We have the Naltrexone available for the National Health Services and available in the private sector. And you can give it in the outpatient after the patient is discharged, and they take it 1 or 2 tablets at the beginning, and then they can give it 1 tablet per day for long periods, at least 1 to 2 years. And it's insured and given to the patient, sometimes completely free. I want to say that the programs, the medical programs and the psychological programs is served for patients in the governmental sector and in the university hospitals 100% free for at least 2 years. Diagnosis, investigations, medical treatment, and all the relapse prevention programs. For alcohol addiction, we don't have it as a major problem in Egypt because marijuana comes first, then the opioids, then the benzodiazepines. But for alcohol, it is present at the beginning, mainly for the use, but for older people, it's less than what's in the West. Disulfiram is available in the private sector mainly, and we have the disulfiram and a compensate. Both of them is available when the patient is suffering from alcohol addiction, and it acts as an aversion therapy to help him to stop it by himself out of the breaking the reinforcement. Family therapy is available because we have family counseling clinics that manage the problems inside the family, help them to be aware about the problem, how to meet the patient, how to meet the patient needs, how to help them to prevent relapse. The other point, which is important, that we have positive family history with most of our patients. So you can treat more than one member in the family in the problem of addiction. You can have a father having the problem, one of the brothers and the friends. Cognitive behavioral therapy, it is dealt with mainly with DBT, usually with patients with comorbid borderline personality and antisocial problems. Motivational enhancement therapy, it goes for long sessions. The 12 steps also available, and we have members from the Narcotic Anonymous. They join the outpatient clinics and the patients in the inpatient department, and they work with them for long terms, and after being discharged they can help them outside and being fellows for most of the patients. The relapse prevention therapy is available for long-term programs for years until the patient is completely safe. The results are not well, and we don't have high results for recovery because managing all this for long-term and having the full working team well-trained and having the available centers and having the available drugs as well as you need is not all the time complete for long time. The moral recognition therapy is one of the psychotherapeutic models, and most of the staff for managing patients with addiction, the psychologists, the social workers, they are well trained how to do it by themselves. So we work as a team. The doctor diagnoses, assess the drug effect, the side effects of the drug, and then a social worker and a psychologist will work with the patient in other modalities of therapy. We have lots of problems of addiction with adolescents now. The problem of adolescents is that addiction is going on with younger age group. They start very heavily with drugs. They can start with heroin from the start. They take synthetic cannabinoids in high doses, and this is going with the adolescent psychological problems, and the increased rate of suicide in this category of age is going as an emerging problem. The antisocial behavior is strengthened more by the internet, because there is a great problem now that this category of age is not more attached to their families than to their peers, to the internet, and so they can imitate what's going on, trying drugs, trying the right to kill themselves, trying to live on their own in separate units. So this is an emerging problem coming with this category of age by time. Thank you very much for your attention, and at the end I need to raise 3 questions.